Welcome back, students. We will continue polycystic ovarian syndrome with the remaining part, that is how we can get the clinical presentation of a female as well as clinical diagnosis and how we can manage. So clinical manifestations. If a woman comes to us with the hyperandrogenism, what symptoms she may come up with? She may come up with acne vulgaris or indurata or rosacea, multiple eruptions on her face, cheeks, forehead, chest. Acne may be seen in the arms also. And androgenic alopecia. This is the male type of baldness or thinning and falling of the hairs. Male gets the baldness at the vertex of this head. So alopecia, male type of alopecia. Hirsutism, it is nothing but the excess terminal hair growth on the face, chin, chest, arms. This is the male type of growth of the excessive hard hairs. So this is the presentation of hyperandrogenism due to testosterone and dehydroepiandrosterone. Now we can also get the patient by ovulatory dysfunctions, in that oligomenorrhea is important as well as amenorrhea. She may get infrequent menstruation and absence of menstruation. This may vary. Absence of menstruation may vary from even through 2, 3 or even 6 to 7 months of amenorrhea. Now, sometime a woman may come with the USG report to us, polycystic ovaries we can find, but to diagnose we should know that at least 10 or more than that, 10 to 12 follicles should be there for diagnosing that she is having a polycystic ovary. The cyst should measure between 2 to 9 millimeters and volume should be more than 10 ml. She may also come up with the pelvic pain, obesity or weight gain, especially around the waist. And this, she may get the acanthosis nigricans. This is one of the important symptoms. These are nothing but the dark brown or blackish hyperpigmented skin eruptions on the posterior aspect of neck, axilla, in the folds like mammary gland or axilla, and thighs. So this acanthosis nigricans is very important clinical presentation. We should pick it up properly. Now, what are the, once again focusing on the 10 important symptoms and signs: irregular periods, absence of menses, thinning of hairs and alopecia. This is acanthosis, skin discoloration, hirsutism, excessive facial hair. She may come with the complaints of acne, weight gain. Some mental psychological upsets with depression, stress are very common here in the signs and symptoms. So normally this is the ovary where ova, when released, this is picked up by fimbria into the fallopian tube, and this mature ova, if it gets fertilized, then the zygote formation takes place in the ampulla part of the fallopian tube. And this corpus luteum now releases the hormone progesterone, which will increase the lining of the uterus for the zygote to get implanted. But in PCOS, what actually happens, body doesn't make any hormone for egg to mature. That is, deficient follicular stimulating hormone may be there. Follicles grow, but they remain immature and hence they turn into the cyst. So as no ova is released due to anovulation, no progesterone is produced. Hence there is no thickening of the endometrium of the uterus. So you can see the multiple cysts in the ovary here. How we can diagnose? Diagnosis can generally be accomplished with the careful history, symptomatology and physical examinations and basic lab testings without the need for ultrasonography. But nowadays this is not the applicable thing. USG becomes a very important tool for PCOD. So diagnosis is basically on Rotterdam criteria. Rotterdam meeting held in the year 2003, the consensus meeting has given us the diagnostic criteria that 2 out of the 3 should be there, either hyperandrogenism, ovulatory dysfunction or polycystic ovaries. So NIH again given us that any 2 out of the 3, same PCOS, Androgen Access PCOS Society and NIH and Rotterdam criteria, all are telling about any 2 criteria out of these 3 should be there to diagnose. either polycystic ovary, anovulation or oligomenorrhea, amenorrhea. But most important, sometimes we don't get clinical symptomatology also, but we get the biochemical evidence. Here, excess testosterone, excess LH, less FSH, these are important to diagnose. Moreover, this is a disease of exclusion. We have to exclude various other pathologies which may look like having a PCOS. In that, we have to exclude congenital adrenal hyperplasia, Cushing syndrome, androgen secreting tumor, hypogonadotrophic hypogonadism, hypothyroidism. So here the congenital adrenal hyperplasia, here the clinical features will be hirsutism, menstrual irregularity, elevation of dehydroepiandrosterone, androstenedione. In cases of Cushing syndrome, we may find facial truncal fat excessively accumulated, then amenorrhea, excessive hair growth. Okay, so we can differentiate whether the symptomatology are similar, but we can differentiate by the presentation and investigation. Ovarian adrenal. Here the too much increase of the hormone testosterone, 750 new gram per ml. So this is the very high figure where we can get this high excess amount of the tumors, adrenal tumors, 700 new gram per ml to diagnose this androgen secreting tumor. Hypogonadotrophic hypogonadism. This causes absence of secondary sexual characters, pubic facial hairs, and development at the puberty. So we can differentiate. In PCOS, this is not the case. Hyperprolactinemia, we may get a new symptom, that is galactorrhea, which is not there in PCOS. And hypothyroidism, we will get all the features of hypothyroidism, that is fatigue, weakness, constipation, depression, memory loss, and irregular menses. So we can diagnose it, differentiate it with TSH findings. So this exclusion is more important to come to the diagnosis of PCOS. Common comorbidities we can find here are the metabolic syndrome, and majority of the women are obese, and we can find the high risk of cardiovascular disease, and they may develop the type 2 diabetes mellitus in future. So increased prevalence of non-alcoholic fatty liver disease, even sleep apnea may occur with dyslipidemia in patients with PCOS. Even when the BMI is controlled, we can find dyslipidemia. So these women or girls may are also prone for mood disorders and depressions. So this is how we can come to the proper diagnosis. For investigation, we can investigate with the following laboratory testings: several hormonal tests, FSH, which will be normal or low, LH definitely elevated, testosterone, usually it is elevated, and we can find testosterone more than 2 new gram per ml. Normally it is 0.2 to 0.8 new gram. Estrogens may be normal, SSBG is reduced, and few tests like TSH, cortisol, prolactin are to rule out their related pathologies. This has to be done. And 17-hydroxyprogesterone to rule out the congenital adrenal hyperplasia. Here we can also differentiate with the dehydroepiandrosterone for the tumor. This is increased and causes the rapidly advancing hirsutism. This is also not good. And we can also go for lipid profile to determine the risk of developing cardiovascular disease and risk of associated cholesterols and triglycerides. So most important is LH to FSH ratio. See, lipid profile, we can find triglycerides more than 150 milligram per deciliters, HDL less than 50 milligram, as well as LH over 10 international units per ml. So these are the important findings. So LH ratio is increased. See, a ratio is more than 2 generally indicates PCOS. FSH is normal or reduced, LH is raised. But there is no exact cutoff values because many different assays are used. So this is important tool, altered or raised LH to FSH ratio for diagnosis. So what gynecologist and what we should go for further evaluation, the blood pressure at every visit we should check, then lipid levels to diagnose. We have to screen the patient for type 2 diabetes and impaired glucose tolerance test. Patient should have, even if she is found normal in PCOS patient, we should screen her for glucose test for every 3 to 5 years for development of the diabetes mellitus. In adolescents, it is very commonly seen after menarche. There is a reasonable, we have to delay the workup for PCOS because adolescent girls may be oligomenoric, means at least 14 years they may have oligomenorrhea or anovulation, which is normal. But even if she is getting more than that, then we should evaluate her for PCOS. If an adolescent is evaluated for PCOS, it has been suggested that she meet all the 3 of the Rotterdam criteria. And we have already seen the lifestyle modifications, weight reductions, it reduces the insulin resistance and can significantly improve the ovulation. So most important thing is weight reduction. And this is considered as a first line of therapy for the management. See, if you want to understand more about development of the steroid pathways, see theca cells. Here excess cholesterol will develop into pregnenolone, which will form a hormone progesterone. Here there is a hydroxypregnenolone will develop, secrete the DHEA, that is dihydroandrosterone. Androstenedione will secrete the hormone testosterone. This whole thing takes place under the effect of luteinizing hormone in the theca layer. Then further this testosterone and androstenedione travel into the granulosa layer and will convert this testosterone into estradiol and estrone with the help of aromatase enzyme. So, but we should remember while diagnosing these cases which are to be referred, serum testosterone, if it is more than 5 nanomolecules per liter, this is to exclude tumors, hyperplasia and Cushing syndromes. We have to exclude levels of testosterone. Infertility, okay, we can deal with infertility very well, but a rapid onset of hirsutism again may cause, exclude the androgen secreting tumor. Glucose intolerance and more than 6 months of amenorrhea with pelvic ultrasound, that we have to advise to exclude the endometrial hyperplasia. USG is an important tool nowadays. There is no need of lab testing if patient doesn't show any physical signs. Suppose there are no physical signs but oligomenorrhea, amenorrhea, we have to evaluate these cases. Even for hormonal imbalances, she may not be a case of PCOS. So what are take-home messages you can take? All women diagnosed with PCOS should be screened for all metabolic abnormalities. Then women with suspected PCOS should be screened for other exclusion diseases like thyroid, prolactin and adrenal hyperplasia. This is how we can diagnose the PCOS.